In this lecture, we'll be talking about fetal and neonatal development some more. So we'll address the face and the palate, and then we'll talk about the GI system. We're talking both fetal as well as transition at birth into newborn physiology. Then we'll talk about the neurological system, renal system, and then skin along with thermoregulation. So for face, I just wanted to put these pictures up just to get you started, and if you can't read them very well, you can see here we're at 11 weeks, 17 weeks, 22 weeks, and 37 weeks. So a lot of changes in that time, and I think probably the most prominent one is just adding on sub-Q fat along the way, and babies are born with plenty of that at the birth. So let's get into a little bit more detail in talking about face and palate development. I guess the main takeaway I want you to see here is that things are starting at the sides, or the lateral portion, and then they're growing together and ultimately fusing in the center. So we'll start up here first, and you can see here we're ending with these being the nostrils. You can see the nasal pits are that little circle. So these yellow pieces here are going to need to fuse together, and then you can see how if you haven't quite fused, the part that's not connecting would be with one of the nostrils there, or the nasal pits. So here we've got our oral cavity, and then it's harder to kind of see what's going on here, so I like to start more at B. But oral cavity, so green we're thinking palate, but then it's the medial nasal processes and the lateral nasal processes here. They need to be able to come together and fuse, or we would have a cleft lip. And then here, just looking at the palate, we're starting on the lateral sides, and then that's our nasal septum. And then they're coming together, and then fusing in the center. And on part of your newborn exam, after each birth, is going to be to put your finger inside of baby's mouth and feel the palate. You can have baby suck on your finger too, which is just a nice reassurance that both the musculoskeletal aspect as well as the neural aspect of sucking is intact. And then you're also feeling that the palate is intact, the soft and the hard palate. So you can see in this picture here, normal lip, normal palate, and then if you had a cleft palate, when you'd go to feel inside, you could feel that divot there. And then you can see this would be a unilateral cleft lip, and then that's what it would look like if our palate was intact, and then sometimes both the palate and the lip will run together. So have it in your mind that just because you have a cleft lip doesn't mean you have a cleft palate, and just because you have a cleft palate doesn't mean you'll have a cleft lip. And then you can see it can also be bilateral, so it would be on one aligned with one of the nares. So, and then that's again what you would be feeling or looking for. And I just have a few pictures here in utero. So unilateral cleft lip, unilateral cleft lip that looks like it's probably extending into the palate. And then a lateral cleft would extend off to the side, which I have yet to see one of those. And then here's the bilateral cleft lip and palate. So gastrointestinal system, you can see here that intestinal contents have herniated into the umbilical cord, but you can't see that as well in this picture, that it's into the umbilical cord. But by 10 weeks, we're expecting that that's worked its way back into the body. So this definitely looks bigger than a 10-weeker, so that would be a gastroschisis or omphalocele. The difference being that the omphalocele has that extra membrane around it, whereas a gastroschisis would not. It would be open, the intestines or whatever is herniated, that would be exposed. And then just a brief note here, if you do see a little bit of an omphalocele, before you go and clamp the cord, make sure that you're not seeing any of it, because if you do, you want to make sure you're clamping beyond the place where the omphalocele is, because that wouldn't be good if we were clamping off part of the intestines, for example. So just being really mindful of that when you're going to clamp the umbilical cord. So GI changes then at the birth. Actually, I just want to pause really quick and head back up. This is just a couple slides up. Just to say after the birth that the number one thing where this can come into play is when you're thinking about breastfeeding. So either way, you're referring on to a pediatrician for ongoing follow-up, but just to be thinking about needing to have a really good suction or seal with mom's breast in order to be able to create that seal with breastfeeding. So that's the main thing you're thinking about after the birth. Okay, so GI changes at birth. So gastric emptying is delayed in that first 12 hours. Stomach is full of mucus. It kind of takes a little bit for everything to get going. That's not to say that you might not have a baby come out full of meconium. So that's on its way out, or has come out before the baby's even born. So that's not a sure thing, but just to be aware that if baby's not going to the bathroom right away, that's not uncommon. So we can see some good meconium here on its way out. So reflux is pretty common in newborns, lots of spit up. And then that first feeding is what's going to help get all of those GI hormones going. Oh, and I think I can extend our screen just, if I can't extend the screen. Sorry, this part at the bottom's a little bit cut off, but I've just put how big baby's stomach is. So a cherry would be like day 1. By day 3, we're a walnut. By a week, we're an apricot. And then after a month, it's about the size of an egg. So that's a newborn stomach. So 98% of babies will have passed their first stool by 24 hours. And that's going to be the mark in your head that you're remembering to tell parents to expect to see it, or that you're watching for it if they're in the hospital for that full time. You'd want to do a workup at that point, or refer on for a workup, either one, if you hadn't seen anything at that point. So passage of stool, that's going to tell us that our GI is patent, so that would be a reason meconium hasn't been passed if you don't have a patent GI tract. And then also seeing stool is just reassurance that that's going to help decrease any jaundice and prevent some jaundice, just knowing that So thinking about growth in the neurological system, we can see here that the neural plates are fusing, and they start by fusing in the center here, and then they work their way up and work their way down simultaneously. And this happens in a pretty short window of time. You can see here over 21 days to 28 days and we're done. So if it doesn't fully fuse, if it's at the top, then we're talking about an anencephaly, where there's no brain development, as opposed to spina bifida if it's somewhere along the spinal cord. So if we don't have a total fusion, that would most commonly be up at the cranium or at the sacrum, so those distal ends, since we start fusing at the center. So you might remember we talked about MSAFP, or maternal serum alpha fetal protein. That's a substance that we can detect that's leaking out of here basically in babies, and we can detect that that's higher in moms in pregnancy, and then once it's totally fused, then those levels go way down. So in certain times in pregnancy, we would expect that those levels would be higher because developmentally the neural plates haven't fused together yet. But then typically somewhere in the 15 to 17 week realm, we would expect that we're fully fused at that point, and that we wouldn't have high levels of AFP. And so if we were to draw mom's blood there and see what her levels of AFP were, if we were to find them to be really high, then that would be worth exploring further if there's an open neural tube defect, so anencephaly, spina bifida, etc. So you can see here on this side with spina bifida, because the neural plates haven't fully fused together, some of the spinal cord can leak out. And this would be in varying degrees and is a little bit beyond the extent of what we need to talk about here. But just being aware that spina bifida occurs more commonly in Caucasians, particularly Irish heritage. And then it's a combination of genetics as well as a folic acid deficiency. And if you have enough folic acid in your diet, that can override genetics. So we recommend all pregnant women get at least 400 micrograms daily when they're pregnant. And basically all prenatal vitamins have about 800. you can see really when this is important is this early point, which I think is huge when you think about how we're educating women at annual exams and starting up with prenatals 3 months before you get ready to get pregnant, because the levels of really all of your nutrition, where you're at when you get pregnant, plays a huge role in setting the foundation for your whole pregnancy. And if women don't start taking prenatal vitamins till much later in their pregnancy, like if they don't realize they're pregnant right away or weren't planning their pregnancy, then we don't have those nice robust levels when we most need them. Or if women aren't starting care, like I know quite a few offices where women really don't start care that early in pregnancy. That's just standardly how it's done. You miss out on all of that teaching. So I think about really taking advantage of annual exams, especially if women are hoping to get pregnant in the next year, and you throw some pre-pregnancy counseling in the mix of that as well. So anytime we have a woman of childbearing age who hasn't chosen a permanent form of birth control, every visit that we have with her we can think of as being, to a certain extent, a pre-pregnancy visit as well. Okay, so let's see what else I wanted to mention with this slide. Oh, so just thinking about folic acid supplementation, if you do have a woman who has a family history of spina bifida, we would want to increase her dose even beyond what we would do for the majority of women at that 400 mark. Typically, I see increasing it even up to 4 grams. So we, as a society, once we started fortifying grains with folic acid, we saw a huge decrease in the rates of spina bifida. So thinking about how midwives can be influencing society from a public health standpoint, I think that's a great example. Okay, neural tube defects. So I just wanted to put up a couple pictures here of real babies. So this is anencephaly, and a lot of the pictures you'll see with these babies, they'll just put little hats on them, and great to be taking pictures. So most of the time those babies aren't going to make it. So giving parents a chance to take some pictures there after the birth. And then this baby's got spina bifida. And then something you always want to check for your newborn exam, you're checking that the spine is straight, and then you're just checking all the way down and seeing if there's a sacral dimple. And if there is a sacral dimple, to be spreading it apart with your fingers to see if it's communicating. Do you see skin at the end of the tunnel, or does it go all the way through? Sometimes with spina bifida, you'll also see like a little tuft of hair. So those would be things you can be watching for when you're doing your exam. So neurological changes at birth, definitely a lot more stimuli once the baby's born. So they're used to just this muted, dark environment where they can really just focus on growing, and the brain development is just happening continuously all throughout pregnancy. And then after the birth, you have this hugely accelerated development with all the increased stimuli, whether that's lights or sounds or touch. It's just a lot. And that environment change is a huge challenge for newborns. So just something to really keep in mind. Birth can get so normal, and it is so normal, but for each one of those babies, it is just the biggest life change they're ever going to have. And wanting to respect them and give them some safe space to do that gently. So we think about the autonomic nervous system. They're doing all of the following simultaneously. So they need to start controlling their respirations and their heart activity, as opposed to mom dictating so much of that in utero, or at least the respirations piece, not needing to do that. And then sucking and swallowing, you think about how much nervous system development as well as musculoskeletal development needs to be in place in order to breastfeed. And then breathe almost simultaneously. And then you've got, so oral feeding, same thing. And then initiation of thermoregulation. They're just needing to do so much more than they were doing in utero. So neurologic development is behind a lot of our motor activity, so thinking about the motor reflex there. And then sensory, sensations are much more intense. you think about listening to mom sing to you when you're in utero versus listening to mom sing to you out of utero, everything is amplified. Oops, lacking that intrauterine pattern, I think I'm referring to our sleep-wake cycle. That might be what I'm meaning there. Let's just switch that right now for you. Thanks for bearing with me here. Okay, and then sleep-wake pattern, they're used to being up at night and then being sleeping more often during the day, and so that organization is just really disturbed, and it takes a while for them to kind of pick that up. And I think this is a huge piece to let moms know, because our society just really expects newborns to start sleeping through the night so soon, and just physiologically, that's not very normal for newborns. So sleeping at night is a learned behavior, and at 6 months, it's about 60% of babies that are actually sleeping through the night. So just something to keep in mind, and let moms know that there's nothing wrong with their babies, and finding ways to help her get good sleep in the midst of that, because certainly that's affecting her as well. So a little bit more on the nervous system here. So reflexes, we can go through all of them, but we'll definitely cover that in your newborn course. So reflexes, they indicate to us that the spinal level at least is intact, because it's that the baby gets a sensation that goes to their spinal cord and then goes right back to where it came from to elicit the reflex, right? So we don't even need our higher cortical centers in order to do that. For example, the Babinski's like that. Once higher cortical centers are more developed, that one disappears. Whereas later in life, like if adults have an injury that can affect that passageway, sometimes the Babinski reflex ends up coming back again. So, as an aside. Okay, so reflexes, they also provide information that both neural and musculoskeletal development is in place, which we've already somewhat talked about. And then just thinking about pain receptors are definitely in place by the birth. By 25 weeks, we have our fibers that can conduct pain in the spinal cord. And then, so both preterm and full-term infants would have all somatic and functional requirements to perceive pain. And I just think about that in terms of just babies really deserving a gentle birth and gentle handling. And they deserve that respect as human beings right from that very first moment of their birth, that we're recognizing what a huge transition in life this is for them, and that we do it as gently as we possibly can. So the renal system, so urinary and genital systems are very closely related. So oftentimes if you see something wrong with one, you might find something wrong with the other one too, or that's worth looking at the other one closely as well. So they develop kind of alongside each other. So kidneys develop from week 5, and then they even begin to function by week 9. And then by 20 weeks, so halfway through pregnancy, fetal urine starts to become a major contributor for amniotic fluid. So that halfway mark, we really think about the kidneys as playing a big role in that. And then that starts in, kidneys rather, are starting in the pelvis, and then they migrate up, and then they rotate 90 degrees to meet up with the adrenal glands. So that's happening during development. And babies contain the same number of adult nephrons by 35 weeks. I don't think I phrased that very well. So by 35 weeks gestation, the baby's going to have the same number of nephrons as we do, but they're a lot shorter and smaller, and so they'll continue to grow. And that hypertrophy continues to happen even into infancy, so that's not all complete by the birth. And then in utero, placenta is controlling excretion function. So after the birth, the kidneys actually have a real purpose, but in the meantime, the placenta is what's doing all of that for us in terms of regulating electrolytes and in getting rid of waste, etc. And then just as a reminder, we talked about this with lung development, but in situations like Potter's syndrome where kidneys aren't developed, You can have oligohydramnios, and you could have that for a number of reasons, but it could be related to the renal system. So oligohydramnios meaning we have a low amount of amniotic fluid. We know that we need that fluid in order to promote and prompt lung development. And then we also need that fluid because that's going to help in utero, just preventing injury to the baby due to compression. So we can thank babies' kidneys for that. So then after the birth, there's some obligatory water loss. So you think about how colostrum doesn't have as much of a bulk to it as breast milk does. That amount of fluid is less. And generally speaking, in the first few days, baby's going to have somewhere in the 5 to 10% realm of weight loss, usually around 8%. We start perking up our ears a little bit more, but until mom's milk comes in, so that's usually around day 3. So maybe day 2, day 3 is going to be the lowest for baby, and then once we can see mom's milk is coming in well, we know we're about to turn a corner, but we have weight loss there. So babies are tend to be born with extra water and extra skin turgor, because they're expecting to lose some of it. So you think about those babies that kind of look like old men a little bit by day 3 because they've lost all that little extra turgor and that little weight loss that puts a bounce to their cheeks, if you will. So let's see here. So changes in systemic vascular resistance that happen with cord clamping in that transition, that's going to improve renal blood flow. So the kidneys really start to function then at that point. We're expecting that babies urinate within the first 24 hours. So for both stool and for urine, we're expecting 1 in the first 24 hours. And then generally speaking, what we say is you add 1 more for each day. So then on day 2, we would expect 2 wet diapers, day 3, 3 wet diapers, and then we even out at about 6 to 8 wet diapers a day, somewhere in that realm. And then if you think about those moms that are worried that their babies aren't getting enough, if something's going in, then something's going to go out. So I think that actually is really empowering for parents. If they're worried about how much their baby's taking in, they're counting how many wet and poopy diapers they're having each day, and that's a huge indicator of how their babies are doing on that front. So if they're not getting enough in, then there's not going to be very much coming out. So that 6 to 8 wet diapers a day is reassuring to moms that their babies are getting a sufficient amount. Okay, so skin. So we know skin is functioning as a barrier, and then there's an acid mantle in utero babies. It's about 5.0, the pH on baby skin, about 5.5, and then it drops to even about 5.0 after the birth, and that helps give some protection against pathogens to be more acidic like that. Skin's helping with temperature regulation, transitional events, would include mechanical stress. So baby's not used to being touched so much, right? And then changes in blood circulation, and then bacterial flora starts to appear as well. And by changes in blood circulation, I'm just thinking about how with babies' circulation being immature right at the birth, you might see like acrocyanosis, where baby's got the blue hands and blue feet, but their core is still staying pink, etc. So skin at transition, skin is pink. And we're talking, doesn't matter what ethnicity that baby is, newborns are just super pink. Fetal hemoglobin has a high affinity for oxygen. Oops. All right, this is the day of correcting my spelling as we go, sorry. Try to click somewhere else, there we go. And then melanocytes are not as apparent at first, so it takes maybe 3 or 4 days for the color of baby's skin, like reflecting their ethnicity, to sink in a little bit more. And it's not uncommon for baby skin to kind of look mottled, especially being in a cooler environment. Or even sometimes you'll see, like, if a baby is laying on one side, that lower half might turn more of like a red, and then the upper half looks more of a white. And it's just immature regulation for their circulation and their nervous system, trying to figure it all out. It just takes a little bit of time, and that's not something to be concerned about. So let's talk just a little bit about vernix. So we see here super cheesy baby. Vernix is protecting baby's skin in utero. And so I think about, if you're in the bath too long, how your skin starts to prune, or it can even become more friable and shear more easily. The Vernix caseosa helps to protect against that in utero. And it has antibacterial properties as well, so it's part of baby's immune defense setup. And knowing that the skin also has that lower pH, Vernix is playing a role in that, and it's not so low that it would burn baby skin, but it really does help to be antibacterial that way. And it is about the most moisturizing substance on the planet. I knew of this midwife who, at the end of every birth, and I'm not recommending you guys do this, but she would just take her hands and smear it on the baby, and then just smear it on her neck and on her upper chest. Old midwife who was just taking all the moisture she could find. So there's no need to be scrubbing this off of babies. Really, if you just give it a couple hours, you'll be shocked at just how much soaks into baby. And you might still see it like in inguinal folds or in armpits the next day, but basically all of it's just going to rub right in, and that's just fine. No need to be scrubbing at it. I'm thinking about being as gentle as we can to baby's skin. So it comes out really fragile. And yet so hardy. Babies are so fragile and yet so very, very hardy, and they are born with some fight in them. So we love them for that. Okay, so thinking just a little bit more on thermoregulation. In utero, babies are just a little bit hotter than mom, and they're able to pass off their heat to mom because of that. So that's done through two ways, either through the amniotic fluid, so passing it off to the fluid, which then absorbs through the wall, or via the umbilical cord to the placenta and then into the maternal blood system. But just be aware that that process is going to take a little longer than it would be for mom. So think about like if mom's in a really hot bath in labor and she gets overheated, all she has to do is stand up, and then just that evaporation and having all that skin exposure to the colder air will help to cool mom off faster, but it's going to take longer for baby to get cooled off that way. So just to have that in mind. And then after the birth, heat loss is really rapid for baby, and they have a large surface area that's not used to being exposed to anything cold, right? So that contributes to that as well. Babies start born with all that much sub-Q fat, so they don't have as much heat protection that way. And then they have high skin permeability and changes at birth, so cooler environment, which can trigger non-shivering thermogenesis. So what are ways to stay warm if you're not really capable of shivering just yet, which developmentally they're not. So let's explore some of the ways that babies are able to keep warm without shivering. So one would be just first, how do we find out we're chilly? So skin cold receptors, spinal cold receptors, and then the hypothalamus will pick up on that. So ultimately, this is all going to result in a release of norepinephrine and T3, so thyroid hormone, and then brown fat metabolism is going to be able to produce more heat. And we'll get into brown fat metabolism in a sec here. But first, let's just go over how are babies losing their heat. And I think these concepts are all really easy to understand in terms of what in their environment is contributing to the heat loss, but I think sometimes the words trip us up. And once you're in practice, do the words really matter if you understand what in a baby's environment can impact their heat? No, the words don't really matter, but I will tell you these words are still on your board's exam. So we have to get these words down because more than likely you will see one of these on your board's exam. So how do babies lose heat? First would be conduction. So that's like a cold object is touching baby. So you set baby on a cold exam table and that makes baby cold. So that's conduction. Convection is mom was super hot in labor, and so you had a fan going, and that fan is still going when that baby's born. And that's going to impact baby's weight loss. So you can see here it's like the air blowing past the baby and making the baby cold. That's convection. So that's just something to kind of keep in mind in those moments when mom's starting to crown and you know the baby's coming soon. Just taking a step back to think about baby's environment and if it's set up well for baby to be nice and comfortable and to have a transition that doesn't involve a lot of heat loss, which sometimes is the opposite of what moms are wanting towards the end of labor. I have worn winter coats through the end of some women's labors, so not the best of environments for babies to be born into. So conduction, touching something cold; convection, like cold air going past baby; and then evaporation is like say you don't dry off baby after the birth and baby's super wet, then baby can be losing their heat through the water as that water evaporates. Or it's like you've dried baby off, but then you leave that wet towel on baby. So wet objects or a wet body. So not to be confused too much with the conduction. If you've got a cold, wet towel on baby, that could maybe be a little bit of both. And then radiation would be cold objects near the baby that aren't technically touching the baby. So let's say it's a cold winter's day and just the wall near where mom gave birth is just freezing because on the other side of it is Minnesota. So that would be radiation. So maybe there's a freezer nearby, maybe there's a cold window nearby. That would be radiation pulling heat towards it. So we'll just memorize those for boards. Okay, so then brown fat. So the easiest way for baby to be able to generate their own heat would be to metabolize their brown fat, which isn't ideal because they only have so much of it, and we want them to be able to save it and store it and keep it for themselves. But this would be how they can generate their own heat if they have to. So we want to create an environment for them where they can keep all their brown fat. But let's just take a sec to understand what brown fat is. So all the pink on these pictures is where you can find the brown fat. So all across here, down the sternum, clavicles, by the kidneys, mid-scapular region. So you can see that there. So how does it work? Basically, small vacuoles, and then it generates high glucose, high mitochondria, so they're having all of these pieces here. So high blood supply, so they're able to generate heat if they need to break it down. To be aware that, just important to be aware that pretermers are born with very little brown fat, so that's a disadvantage they have right from the start. And then 2 to 7% of a newborn's weight is brown fat. So it has a large amount of heat, but it's pretty costly to be losing it. So let's talk about cold stress. And I apologize if this screen is a little bit hard to see. I wanted to at least give it a title, but then decided we just needed to make this as big as possible. So the overarching title for this slide would be cold stress. So this is cold stress, or decreased body temperature. How did we get here? Evaporation, conduction, convection, radiation, any of these can contribute to a baby being in cold stress. So what is a baby going to do to try to counteract that? We talked about T3 levels going up, so a high metabolic rate. High metabolic rate means burning off a lot of glucose. Okay, great, now we're warmer, but now we might be hypoglycemic. So that's not really the gentlest of states to start in. High metabolic rate also means using a lot of our oxygen, which ultimately we can become hypoxic, and then we're also thinking about respiratory distress. We're blowing off all of our CO2, and we can end up in respiratory alkalosis, right? What's another option besides increasing our metabolic rate? Well, we can metabolize our brown fat. We know we have some of that available to us, and if we're really cold, we gotta do what we gotta do, right? So increased production of acids. So as we metabolize the fat, we're releasing acids, and that can result in metabolic acidosis. And also, that can be a competitor for the bilirubin that's binding to albumin. Remember, in order to get bilirubin over to the liver and ultimately to get it out of our system, it needs to be bound to that albumin. And If there's competitors for that, basically this will displace the bilirubin off of the albumin, which can lead to jaundice and just more bilirubin in a baby's system that can travel to other areas in the body rather than being confined to the blood. So thinking about it leaking out into the brain, for example. And then the other thing baby can do is vasoconstriction. So constricting peripheral vessels, you think about babies with pale, cold, mottled skin. A little bit of that is not surprising, but just if you're seeing it, being conscious of, well, what is baby's temperature? Could we add a hat? Let's get baby closer to mom's chest and kind of snuggled in there, put a blanket over both of them, that kind of thing. Let's see what are little things we can do to just tweak baby's situation to be more gentle and warmer. And then pulmonary vessels are also constricted, and then that can change our fetal circulation pattern, thinking back to respiratory distress again. So all of those components play into it. So that's cold stress. And then for our last picture here, just as we're wrapping up fetal development and that neonatal transition, is just to think of that really thinking about having a fair playing ground for all of babies and then ultimately all of children and all of adults. It really starts at the womb. Health disparities begin in the womb. So thinking about mom's nutrition and what she has access to and the education mom has access to in terms of being able to keep herself healthy. So whether that's education or whether that's access to resources, really health disparities are beginning in the womb, and what can we as midwives do to have all of these babies have a fair start at life. I think about Amos 5, where God is just so frustrated with the Israelites for how they have all of their songs that they sing to him and all of their religious festivals, and they're doing so many things right, and yet the poor in the land are just suffering so much. And God tells them, what I'm most wanting is that justice would roll on like a river and righteousness like a mighty stream. And I think as midwives, we help to create that fair and that equal place for all people by providing women with education and a safe space. And I think about how socioeconomic and racial disparities are huge in the U.S. And how midwives are really at the front lines in helping even out the playing field for preterm labor and in infant mortalities. What are we doing in order to create a fair society that is honorable and righteous and just? I think us understanding that all of these babies are being created in God's image and are just so dearly loved by God, that is such a starting point for us as believers to be fueled to advocate for all babies. And midwives are certainly at the forefront of, as a whole profession, desiring to create an equal playing field. I love that as a profession, we tell all other professions that a hallmark of who we are is that we want to be caring for vulnerable populations, and that we want to be empowering women as partners in their healthcare, no matter what their past has been, and that we're ready to walk alongside women as they look to change their lives and to change their families. So just a really beautiful place to be. Okay, have a good week, everyone. You know how to reach me if you have any questions.